Welcome. This is the Multiple Sclerosis Highlights Report and Best Practices Clinical Highlights from the 2016 ECTRIMS meeting. Hello, my name is Daniel Ontaneda. I am a staff neurologist at the Cleveland Clinic Mellen Center for Multiple Sclerosis, and I will be talking about research on oral medications that was presented at the ECTRIMS 2016 meeting. I would like to start with talking about a presentation that focused on switching therapies in relapsing remitting MS, a real-life multicenter experience. This was a very large study conducted by Clerico and colleagues at ECTRIMS 2016. What the authors did was an observational study describing switch patterns from subjects with relapsing remitting multiple sclerosis. A total of 1,452 subjects from 17 Italian MS centers were collected. Switch occurred in 44% of subjects by year 3. Switching was most commonly for inefficacy of prior medication, and predictors of inefficacy were younger age, recent diagnosis, delay in diagnosis, and spinal cord lesions. This is kind of the crux of where I wanted to start this conversation with, this topic with, because it's important to know, well, one, which patients are switching from a platform therapy to an oral, why are they switching, and it seems here that the most common cause was inefficacy, and then what did they switch to? And so these authors found that among the oral medications, 21.4% switched to fingolimod, 13% switched to dimethyl fumarate, and 5.2% switched to teriflunomide. So overall, I would say oral medications represent 40% of switch medications, and most switches are due to inefficacy of prior DMT. Next, I would like to look at some comparative effectiveness or comparative efficacy studies. First, let's look at comparative analysis of MS outcomes with dimethyl fumarate and other DMTs. This presentation was conducted by Spellman from the group in Melbourne on behalf of the MS-based group, which is a large multiple sclerosis registry from across the world. MS-based registry basically compared the time to first relapse, the annualized relapse rate, discontinuation between commonly used oral medications, dimethyl fumarate, fingolimod, teriflunomide, and injectables. A total of 415 fingolimod patients were matched to 415 dimethyl fumarate patients, and dimethyl fumarate was associated with an increased risk of discontinuation. There was no significant difference in the risk of relapse for dimethyl fumarate when compared against fingolimod. So this basically is showing us that registry data once again shows that there is no significant differences between efficacy rates in real-world populations between fingolimod and dimethyl fumarate in relation to relapses. A common trend that has been seen in several observational studies comparing these two medications is that more discontinuation was observed for dimethyl fumarate, and this was likely due to side effects. Next, I want to focus a little bit on safety and efficacy of dimethyl fumarate. This was a study by McLeod et al. From Bochum, Germany. It was a cohort study of 664 relapsing remitting patients treated with dimethyl fumarate at 2 large German MS centers. The annualized relapse rate overall was reduced by 33% in this group of dimethyl fumarate treated patients. There was a subgroup of patients who were coming from interferon or glutamer acetate, and they had a reduction of 72%. They found that a total of 28.7% of patients discontinued DMF, and they found that lymphocyte counts below 1,000 was found in about 35% of patients. What this study shows is that it confirms the clinical efficacy in a large real-world study. We see that the reduction in the annualized relapse rate was significant, especially for the patients who were switching from an interferon glutamer acetate, and most likely they were switching due to inefficacy. And we saw a significant reduction in the amount of relapses on study medication. This study found a relatively high discontinuation rate, so approximately almost 1/3 of patients had to discontinue medication, and this was likely also related to side effects. Now moving on to safety and efficacy of fingolimod. This was a study published by Torbe. It was one of the largest observational studies of real-world fingolimod use from different centers in France. There was a total of 1,014 patients. First-line use of fingolimod was relatively high compared to the majority of the American observational studies, with 20.12% of subjects being first-line users of fingolimod. The annualized relapse rate reduction was 83.75 for year 1 and 90% for year 2. The fingolimod discontinuation rate was 17.42, and mostly due to intolerance. And a decrease in the lymphocyte count less than 1,000 was observed in 93% of patients. So if we contrast this abstract with the previous abstract, one can get an idea more or less of how these two different medications vary. One can see that overall the discontinuation rate was relatively high for both, slightly higher for dimethyl fumarate, but due to intolerance for both. And we also see that the drop in the lymphocyte count in the fingolimod treated patients, less than 1,000, was observed in almost all of those, which wasn't the case, or the case wasn't as likely in the dimethyl fumarate group. So essentially, this abstract confirms efficacy on relapses. It's notable for a large proportion of first-line users of fingolimod, and it contrasts the discontinuation on lymphocyte counts with dimethyl fumarate. Finally, I would like to talk about Cladribine, real-world studies and clinical trials. This was research presented by several authors at several abstracts, Giovannoni from London and Dr. Kalinick from Melbourne. And basically this was two studies. One was a pool data from the clinical trials Onward and Clarity, and they looked at different NETA proportions with the different study arms. So they found that the NETA proportion with a 3.5 milligram per kilogram was 41.7%, for 5.25 milligrams per kilogram was 43.6, and for placebo was 15.1. The real-world data from the Australian investigators examined 90 patients who were treated with Cladribine, showed an abolished trend of increased EDSS in subjects treated. So overall, what I would say is that this oral therapy, Cladribine, is not currently approved, but I wanted to highlight it because there were some presentations that showed good evidence in regards to efficacy, and also to remind clinicians that this medication is being resubmitted to regulatory agencies and may be an option in the future. But I do want to clarify that currently it is not approved to treat any form of MS in the United States. That is all my updates from the ECTRIMS 2016 meeting regarding oral therapies. Thank you very much for your attention.